Welcome to another video where we could talk about hypertension and especially in patients who will undergo anesthesia. So in the next slides we'll talk about hypertension, classification, etiology, possible complications or risk factors, and of course treatment. The second one is a main and accomplish anesthesia preparation, a preoperatory preparation assessment, possible intraoperatorial complications, and period during awakening or recovery of the patient. So let's start with classification. In front you see American Heart Association classification. It possibly differs from the European guidelines, and let me tell you every of this one. So stage 1 is considered from 130 and higher in American Heart Association, in times that European guidelines retain the previous definition of hypertension, like stage 1 more than 140 per 90 blood pressure. Whereas American guidelines lowering the threshold to define hypertension because of detecting early stage of the disease and start as soon as possible treatment. Normal range is less than 120 per 80, and this one is called pre-hypertension or elevated. And this is the next stage, like stage 2, 140 and higher, and 90 and higher, and hypertensive crisis, as you need consultation of the doctor and a special care or treatment. And values are more than 180 and more than 120. So this column is for systolic and second one for diastolic blood pressure. What are the causes of hypertension? We know two mains, like primary and secondary. Primary occupy around 95% of hypertension. It is idiopathic as cause is unknown, and secondary is from organ or system of organs that contribute to the increase of blood pressure. So first one is the renal disease. Any of the renal disease, and especially renal artery stenosis from different causes, or a glomerular disease like glomerulonephritis, as well increase blood pressure. How about endocrine system, where we have many examples like Cone syndrome or pheochromocytoma. In Cone syndrome, there is a tumor that secretes aldosterone, which increases the reabsorption of sodium, which pull inside on a renal system water as well. And pheochromocytoma, which secretes norepinephrine or epinephrine. It's a sympathetic drug, adrenergic sympathetic drug. And pregnancy related, like preeclampsia, which is triggered by problems on the level of placenta. So placenta do not receive the amount of blood that necessitate, and they increase secretion of many hormones that contribute to increasing blood pressure. Let's go on a slide with complications. As you see, stroke, myocardial infarction, heart failure, renal failure, hypertensive retinopathy, and progression of atherosclerosis. So blood pressure have two components: cardiac output and of course peripheral vascular resistance. All of them are from peripheral vascular resistance, where vessels are more rigid, do not contribute to the exchange between the vessel and tissue well. And of course it progresses in time, and vessel become very rigid, and permeability is decreased. How about treatment of the hypertension? You see a list of drugs like ACE inhibitors, ARB inhibitors, diuretics, beta blockers, calcium channel blockers, alpha blockers, especially alpha 1 blockers, which produce vasodilation, and alpha 2 agonists, which act centrally on the central nervous system as inhibitor of the central nervous system, and renin inhibitors. So usually doctors prescribe diuretics, especially thiazide. They are starting with diuretic, thiazide, thiazide, and after they can add any of the other drug like ACE inhibitor, beta blocker, or calcium channel blockers. As well, treatment for hypertension could start with lifestyle change and of course diet, which is very important. Low diet in salts and lipids or fats. And second part of our lecture, anesthesia in patient with hypertension. We see preoperative assessment. You should confirm firstly that patient have hypertension and it is primarily detected. If it is primarily detected, you know that rule of 2 weeks, patient should come back to you and you measure once again to establish the diagnosis or to confirm it. So establish current treatment if disease is confirmed and confirm efficacy of the drugs or pills that patient take. Search for end organ damage, comorbidities. You can also assess patient by doing EKG, echo of the heart, electrolytes, disturbances. And of course, you should continue antihypertensive medications, including the morning of the surgery, except ACE inhibitors. Patient with hypertension could have a lot of problems during the surgery, and we are interested in anesthesia. During induction or maintaining of anesthesia, we are giving to the patient different anesthetic drugs. Almost of them have side effects like increasing or decreasing blood pressure. Increasing or decreasing blood pressure as well as heart rate and contractility, of course. So problems that could appear during the anesthesia are labile blood pressure, subendocardial, myocardial, ischemia, exaggerated response to the drugs or to the anesthesia, compromised blood flow to organs and fluid balance. So patient, if have congestive heart failure and hypertension, you should not give too much fluids or restrict fluid giving to the patient. One of the way to monitor blood pressure during the anesthesia is to insert a special catheter called invasive blood pressure, usually in the radial artery, and monitor blood pressure accurately during the whole anesthesia. What are the problems postoperatively? Of course, pain, hypoxia, hypercarbia. Hypoxia and hypercarbia are together, and fluid overload, hypothermia. All of them can lead to increased response of the body, especially increasing sympathetic outflow and increasing blood pressure. Important thing to do right after the extubation or removing of the orotracheal tube is to give supplemental oxygen to the patient. It is considered well doing. So hypoxia, hypercarbia are removed from this list immediately as you are giving oxygen and patient do not have additional pulmonary problems. When to cancel hypertensive patient for operation, and should you do this? Of course, if patient have severe hypertension, the main thing is to prepare patient initially and after uh, to go for anesthesia. If patient have moderate hypertension and end organ damage, but it is going for elective surgery. Elective surgery you can postpone, give treatment, or readdress patient to the cardiologist or internal medicine doctor, and after 1 month of the treatment that is working, of course, a patient come back and you make a schedule for operation or for surgery. If patient have also mild hypertension but have elective surgery, you do the same thing. Only if this is a emergency, urgency, and you do not have time, you can give preoperatively some drugs to lower blood pressure. But do not forget that some patients are showing to you exaggerated response to the drugs. Hope this one is useful for you. If yes, you can subscribe and follow. Have a great time, guys.